Hey everybody, this is Alex. Today I'm going to be going over a case report that I presented back in our surgical pathology practicum at the end of the year. I chose to do a case report on a pleomorphic adenoma, which is a benign mixed tumor. Typically affects salivary glands, most commonly the parotid gland, which was the case for this patient. And we'll just go ahead and get started. So the clinical history, we have a 46-year-old white female with a left parotid mass that had been enhancing and increasing in size for many years. She had no effect on her face. There was no weakness or pain or anything, but she did have a previous fine needle aspirate biopsy and imaging a year prior to this visit, which proved a 3 centimeter mass. And the fine needle aspirate showed a histologically confirmed pleomorphic adenoma. So her pleomorphic adenoma was in her parotid gland, although it can be in other places. But just to give you an idea of the parotid anatomy, you have parotid glands on both sides of your face. It's a bilateral structure. There's the anatomic division of deep and superficial lobes. And the main purpose of the parotid gland is to secrete serous saliva to aid in food breakdown. And so these saliva secretions are transported via a duct down into the buccinator. And you're bounded by superiorly by the zygomatic arch, inferiorly by the inferior border of the mandible, which is the lower bone of the, I guess, the jaw, the masseter muscle anteriorly, which is like a chewing muscle, and then posteriorly, it's bounded by the external ear and the sternocleidomastoid. So at her evaluation prior to surgery, she didn't have anything really to comment on besides on the head and face area. She had this firm 3 to 4 centimeter parotid mass, which was mobile. And that was to be expected since she had previous imaging and the pathology already on it. So when grossing the specimen, I noticed that the gland revealed just a very nice homogeneous cut surface. These can range from being like a yellowy tan, just like homogeneous cut surface, up into being more of this like blue dash gray, like mixoid appearing, like almost like crystallized, but still like a rubbery soft cut surface. It just depends. And so here's my dictation. It was received in formalin, labeled with the patient's name and medical record number, designated as left parotid mass. It was unoriented, measuring 4.1 by 4.0 by 2.4 centimeters and weighing 16 grams. The external surface was pink and glistening, roughened, cauterized, and nodular. I went ahead and inked the specimen in black and serially sectioned it, and it revealed a tan, white, glistening, well-circumscribed mass measuring 3.5 by 3.5 by 2. The capsule of the lesion was intact. It did abut the external surgical margin, but the uninvolved tissue around the lesion was tan pink glandular, and there was a little bit of hemorrhage off to the side. And I just went ahead and submitted some representative sections: lesion to surgical margin, lesion to normal parenchyma, and lesion to that little hemorrhage. So on the final diagnosis, it was pleomorphic adenoma, which, because she had a biopsy prior to getting the whole thing taken out, that wasn't any crazy news. But the good news is that resection margins were uninvolved by the lesion. And the way that our pathologist diagnosis is based on the sections that I decided to take from the main specimen. This is what it looks like underneath the microscope. So you can see how, sorry, I keep going back and forth. You can kind of see how the pathologist assistant really plays a pivotal role in how slides are made and how the sections that come out for the pathologist to read can either be really, really good or could be really bad. Or, if you don't have the right person picking the right sections and knowing what they're looking for, your pathologist might not even get the area of interest that they should be looking at. So we go through a lot of training for this. I'm currently in my clinical year, which is me basically learning what I should and shouldn't be doing, in hopes that whenever I get out into the real world and I'm a practicing PA, I will give the best sections possible that I can to my pathologists. But back to this, under the scope, you see epithelial and myxoid components with a spindle cell background. And if you don't have any experience in histology, that could basically just sound like a bunch of jargon. This is definitely not a skill that you pick up overnight. Pathologists, well, all doctors go to medical school, but pathologists then do 4 years of residency training in pathology, and then they usually go on to fellowship, and then they might subspecialize it with something else. So it's really hard to look at things under the scope and know what you're looking at. And so just really appreciate your pathologists. But basically, the darker staining purple is normal parotid gland with some serous cells, and you can kind of see that on this like outer rim. And then this kind of lighter pink is the pleomorphic adenoma, and they have some scattered ducts and this is like fat. You can see these little like fat pockets here, and then some fibrous bands that were probably surrounding the actual pleomorphic adenoma. So some facts about PAs, or, not pathologist assistant, but pleomorphic adenomas. They make up 50 to 60% of salivary gland tumors, and they're typically just these slow growing masses. They're a mixture of ductal, epithelial, and myoepithelial cells, to where they make these mixed tumors from different types of differentiation. A risk factor for developing these could be radiation exposure. And typically they're well demarcated, and they have this water chestnut like consistency. So if you think like when you go to a Chinese food restaurant and they give you those little water chestnuts that you have to cut into, and they're kind of like crunchy and almost like, I don't know, they just have this like funny little texture on the surface. That's typically what these feel like. I will say that this particular lesion was a lot more soft than a water chestnut consistency, but the few that I have done in clinical year have been very typical water chestnut consistency. They're usually under 6 centimeters, and the cut surface is usually like a gray-white myxoid or a blue translucent chondroid. So it can be like a mixture of like this cartilaginous and fibrous type of like stroma. So epidemiology, they typically have 2 to 3 cases per 100,000 of population. This can arise in the 3rd to 6th decade of life. It has a 2 to 1 female to male ratio. And like I said before in my little introduction, usually these tumors affect the parotid gland, but you do have other salivary glands. So it can go to your submandibular gland or minor salivary glands. So it's usually a benign process, but they can undergo malignant transformation, which is why you need to assess the capsule and look to see if there is any like invasion out of the capsule. So when patients undergo a parotidectomy and they get their whole parotid gland out, the rate of recurrence is only 4%. They used to have this procedure called enucleation, but it's really not performed that much anymore because it has a higher chance of like recurrence. So why do that when you could just take the parotid gland out? So if you leave these pleomorphic adenomas in and you just wait and watch them over time, they will or can undergo malignant transformation into either an adenocarcinoma or some form of an undifferentiated carcinoma. So if you have the pleomorphic adenoma for less than 5 years, it's only like a 2% chance of transformation. But the longer you let it sit inside the patient's body, over 15 years, you just raise the risk of it transforming to some malignancy. So pathogenesis, there's like a few, I guess, things that could be going on. It's still not well established or understood. There is a gene that's a critical cytoprotective mechanism and provides antioxidant responses, the NRF2 gene. And so pleomorphic adenomas show some cytoplasmic and nuclear NFR2 expression in their epithelial and serous cells. And so through the exposure to any type of like reactive oxygen species or electrophiles, they have an inactivation and NRF2 is stabilized. So typically you have NRF2 to regulate antioxidant response and promote survival of normal cells and to protect cells from insults like chemo or radiation. So if you lose that regulation, that's why when patients are exposed to radiation, they have this chance of developing a pleomorphic adenoma. Morphologic features, like I said before with the histo, you got this epithelial and spindle-shaped myoepithelial cells with either a cartilage or hyaline or myxoid or mucoid background, which is why sometimes it can be like a tan gray color. It can be like a blue kind of translucent, like cartilaginous color. The tumor lacks a true capsule and is otherwise surrounded by a pseudocapsule, which can vary in thickness. And so if it transforms into like the malignant form of this, the tumor then extends through the parotid gland parenchyma as like these finger-like projections. And to diagnose, really just like this patient, she had a fine needle aspirate biopsy, or you could do a core needle biopsy. They have low tumor seeding rates. FNA has 90% sensitivity. Core needle biopsy has 97% sensitivity and is more accurate, but it's a little bit more invasive. So I think the FNA is just, the choice over a core needle biopsy. If patients have a CT scan, it's usually seen as a smooth, marginated, or lobulated soft tissue mass. And you can get a special type of like post-contrast MRI, which would show like perineural spread if they think that there is a chance that it has undergone a malignant transformation. Treatment, typically you want to do that parotidectomy. The enucleation procedures have been eradicated due to those high recurrent rates. But the parotidectomy is usually a modified facelift incision, dissection of the facial nerve, which you have to be super duper careful about so that patients don't have facial paralysis or some type of like nerve damage with this procedure. Even though it is typically a benign tumor, it's it's your face and it's the side of your face, and it's a pretty invasive procedure. And then there's reconstruction with superficial musculoaponeurotic system flap. So again, the facial nerve has to be preserved whenever it's involving the parotid. It's, you need to have at least a 5 millimeter margin when involving the minor salivary gland. So these are some pictures intraoperative of dissection of the parotid gland, thanks to Dr. Wavelkar. And as you can see, this is a pretty big incision on the side of the face in order to get that parotid gland out and to spare the facial nerves. So outcome, you can have facial nerve injury. It can happen. Patients need to participate in an eye care program and use lubricating drops. Just to like make sure that if there's any issues with the facial nerve and they're not able to like blink their eye correctly and do certain things with their facial structures, that they're taking care of their eye or other like structures, mouth, nose, that may be affected. It could take months or years to recover eyelid function. Patients who have issues with speech after because of facial nerve injury may have to go to speech therapy. And then statistically, there's a relationship between facial paresis and tumor location in the superior and lateral area of the superficial lobe. And that's about it. So thanks, guys. Hopefully it wasn't too long. I was trying to get through it quickly just to have like a nice little refresher on this type of tumor and what we should be doing with it as PAs. Obviously describing the cut surface, that, myxoid, chondroid, translucent blue-gray cut surface, and, kind of talking about the capsule and, if it's all intact, and any type of strange like capsular or outside invasion outside the capsule is important to note. And, as always with a parotid gland, like I think it's important to look around and see if there's any like nerves hanging off or before you ink it, just because you'll kind of lose sight of it. So, all right, well, thanks.